The active stand test, which is also called the poor man's tilt table test, is often used to diagnose conditions like POTS, orthostatic hypotension, and more. So let's do one together. Major disclaimer from the very beginning, please be careful while you're doing this. It's ideal to have someone with you to spot you, and of course, if you start feeling dizzy, lightheaded, please sit or lie down. This video isn't meant to be used as a diagnostic tool, and you should always speak to your provider about any concerns. To start the active stand test, find a place to lie down flat. If you're lying on your bed, make sure that you are not using a pillow. At this point, you're going to put your blood pressure cuff on, your pulse ox. I just end up using the heart rate from my blood pressure cuff. It's always accurate and shows exactly what's on my pulse ox. And then you're going to start your 5-minute timer. For this entire 5 minutes, you are going to just lie there, relax, and this is how you're going to get your resting heart rate and blood pressure. So while we're laying here relaxing, let's talk about the active stand test versus the tilt table test. Both tests are used to evaluate the body's response to standing up from a supine position by looking at the patient's heart rate and blood pressure changes, or gathering what is called orthostatic vitals. The tilt table test is the gold standard for diagnosing conditions like POTS and OH, and that's because it's the most accurate diagnostic tool we have. With that being said, the formal tilt table test is much more challenging to access, which is why doctors will often perform active stand tests in the office instead. It's important to note that recent research found that the active stand test failed to identify 26% of adult POTS cases that were later identified by the formal tilt table test. And those findings are similar to research on pediatric patients, which found that the active stand test failed to identify nearly 60% of pediatric POTS cases that the tilt table test identified. So while the active stand test is more accessible, it's not as accurate. Why is that? For a tilt table test, everything is standardized and controlled. The table is typically tilted to 60 to 70 degrees. It's consistent across most studies and clinics, which makes the data comparable. Now, another factor that has a large effect on the accuracy of these tests is the muscle pump activation or the lack thereof. During a tilt table test, you are passively moved upright while strapped in, meaning you do not have to engage or contract your muscles. The same cannot be said for the active stand test, where you're engaging your leg muscles to stay upright. This naturally helps pump blood back up to your heart, which can mask your true autonomic response, which could potentially lead to a false negative. That's why it's so important that you don't shift your weight or sway during your active stand test. Because you're passively moved upright during a tilt table test, it eliminates the muscle pump effect, which allows clinicians to observe the natural autonomic response. And maybe that autonomic response is dysfunctional, indicating you might have POTS, OH, VVS, or another type of dysautonomia. So what would a dysfunctional autonomic nervous system response look like? Perhaps a significant increase in heart rate upon standing, which could indicate POTS. So let's go over its internationally accepted diagnostic criteria. First, there must be a sustained increase in heart rate of at least 30 beats per minute within the first 10 minutes of standing. For individuals who are 12 to 19 years old, that increase in heart rate must be at least 40 beats per minute. Now, you'll notice that they don't specify how long this heart rate increase must be sustained, and that's because experts have been urged to avoid creating arbitrary requirements like the heart rate has to be sustained for 30 seconds because it's not based in science. The POTS heart rate criteria was developed based on percent deviation from the norm, and no time duration for the heart rate increase was used in the initial studies that set the POTS heart rate criteria. The second piece of criteria that must be met to get a POTS diagnosis is that there must be an absence of orthostatic hypotension. Now, we'll get into the diagnostic criteria for orthostatic hypotension shortly, so let's move on to the third piece of diagnostic criteria for POTS, which is that there must be frequent symptoms of orthostatic intolerance with rapid improvement of symptoms upon returning to the supine position. The fourth piece of diagnostic criteria is that there must have been a duration of symptoms for at least 3 months, which isn't shocking, it's a chronic illness. And then the last piece of diagnostic criteria is that there must be an absence of conditions that could explain tachycardia, like anemia, dehydration, deconditioning, anxiety disorders, pheochromocytoma, hyperthyroidism, and others. The wording for this last piece of criteria can be kind of confusing. When a lot of people see this, I know that they're thinking, wait, does that mean I can't have, for example, anxiety and POTS? No, that's not what it means. Think of these conditions as things that must be ruled out or treated and managed before a POTS diagnosis can be made. For example, if a patient is treated for anemia and their tachycardia resolves, then they had anemia and not POTS. If their anemia is treated and their tachycardia persists, then they had anemia and they also have POTS. Now, let's use hyperthyroidism as an example. If a patient's hyperthyroidism is treated and their tachycardia resolves, then they have hyperthyroidism and not POTS. If hyperthyroidism is treated and the tachycardia persists, then they have hyperthyroidism and they also have POTS, assuming of course that they meet the rest of the diagnostic criteria for POTS. Let's return now to the second piece of the POTS diagnostic criteria, that there must be an absence of orthostatic hypotension. That will lead us into what is the diagnostic criteria for orthostatic hypotension. Orthostatic hypotension is defined as a significant drop in blood pressure of at least 20 systolic or at least 10 diastolic within the first 3 minutes of standing. Orthostatic hypotension can be a type of dysautonomia, but it's not always. There are many causes of OH, both neurogenic and non-neurogenic. Non-neurogenic OH has no neurologic or nervous system cause. So some examples of non-neurogenic causes: hypovolemia, heart failure, venous pooling, alcohol, advancing age, medications, cortisol deficiency, and more. So these are all conditions that can cause orthostatic hypotension, but they have nothing to do with the nervous system. Alternatively, neurogenic OH is due to autonomic dysfunction, the dysfunction of the autonomic nervous system, which we know is dysautonomia. Let's pause our orthostatic hypotension conversation for a second. Once your timer hits 5 minutes, you're going to take your heart rate and blood pressure, and these will be your resting vitals. Notice that I barely moved when taking these vitals. I did not sit up. Make sure you remain in the supine position while you're doing this. Once you've taken note of your resting heart rate and blood pressure, prepare to stand. Remember, we will not be sitting in between aside from rolling off your bed or your couch. Unfortunately, there are many doctors who perform the active stand test in their office incorrectly by including sitting in between the supine position and the standing. But the initial studies that set the POTS heart rate criteria were based on the heart rate and blood pressure in the supine position and the standing position. So once you have your resting heart rate and blood pressure, you're going to stand. And as soon as you're on your feet, you're going to start the timer leading up to 10 minutes, and you're going to take your heart rate and blood pressure again. This is going to tell us your initial standing heart rate and blood pressure. This is an excellent time to remind you that if you start feeling sick, if you start feeling faint, lightheaded, dizzy, like you might collapse, please stop, sit down, lay down. We do not want you to be injured. Try to get up at a pretty normal pace so you can catch your body's true autonomic response. If you leap up out of bed, then you might immediately become symptomatic. Your heart rate might increase more than it would have. Or if you get up too slowly, then that could mask your autonomic response. It is not a moral failing if you can't finish the active stand test. It's okay. There are many, many people who can't, myself included. That's why you might notice some cuts in this. I couldn't finish it in one go. I had to pause, lie down for a while, and then stand back up. But it was okay for me to do that because the data doesn't actually matter. I'm just filming this to show you. If I were doing a legitimate active stand test to get the real data, to see what's going on, if I wanted to take that to my doctor, I would not be doing the active stand test, stop, lie down until I felt better, stand and start in the middle, and then keep doing that. It just would kind of defeat the purpose of doing the active stand test, because if you're lying down, then you're going to become less symptomatic and your heart rate is going to lower. So when you stand, it's not going to be a good indicator of what your heart rate is doing when you are upright, because it'll just be going back and forth. So while you're doing this, make sure you keep standing as long as you can without fainting and injuring yourself. If you start feeling sick, I'm telling you, you better sit or lie down. The next time you're going to take your standing heart rate and blood pressure is going to be at 2 minutes and then again at 3 minutes. When performing an active stand test, most of the time it's done in the office. Some physicians will only take heart rate and blood pressure readings when the patient has initially stood up at 2 minutes, at 5 minutes, and at 10 minutes. Others will do when the patient has initially stood up 3 minutes, 5 minutes, 10 minutes. So when I do active stand tests, I just include both the 2 minute mark and the 3 minute mark, and then 5 minutes and 10 minutes. So continue standing as long as you're feeling okay and you're not going to pass out, and keep an eye on your timer. You're going to take your heart rate and blood pressure readings at 2 minutes right now with me, and then again at 3 minutes. So remember, we were talking about orthostatic hypotension and about how sometimes it can be dysautonomia, but it's not always. There's non-neurogenic OH, which we talked about. Non-neurogenic meaning there's no neurologic or nervous system cause. Some causes of non-neurogenic OH: hypovolemia, heart failure, alcohol, medications, and more. Alternatively, there's neurogenic OH, which comes from autonomic dysfunction. Autonomic dysfunction is the dysfunction of the autonomic nervous system, and that's dysautonomia. So remember, earlier on in this video, we talked about what a dysfunctional autonomic nervous system response might look like. And I mentioned that it could look like an increased heart rate upon standing with symptoms of orthostatic intolerance, which might indicate POTS. But there's much more to dysautonomia, to a dysfunctional autonomic nervous system, than an increased heart rate. So let's dive a little bit deeper into what dysautonomia is, what the recommended first-line treatment for POTS and OHs, and at the end of our active stand test, what to do with your results if you're concerned. We've been standing for 3 minutes, so don't forget to now take your blood pressure and heart rate again and continue standing if you're able. So now dysautonomia. Dysautonomia is an umbrella term used to describe several autonomic nervous system disorders. So as I've said several times in this video, dysautonomia is the dysfunction of the autonomic nervous system. The autonomic nervous system regulates the involuntary responses of the body. Involuntary meaning we don't have to think about them, they just happen. Heart rate, blood pressure, respiration, digestion. We don't have to think about them and make them happen, they just happen. Imagine if we had to consciously think about our respiration. If we stopped thinking about it, we would stop breathing and it wouldn't end up well for us. The same goes for digestion. We don't have to sit here and think really hard about digesting our food. It just happens thanks to our autonomic nervous system. But when your autonomic nervous system is dysfunctional, that causes dozens of symptoms across multiple body systems. Since dysautonomia affects so many body systems, there is a wide variety of symptoms. Lightheadedness, dizziness, brain fog, fatigue, chest pain, chest tightness, shortness of breath, nausea, excessive sweating, not sweating at all, not sweating enough. Of course, tachycardia, which means a fast heart rate, bradycardia, which means low heart rate, high blood pressure, low blood pressure. Syncope, which is fainting, or pre-syncope, which is feeling like you're going to faint but not actually fainting. Weakness, tremors, pupil dilation when they shouldn't be super dilated, pupil constriction when they shouldn't be super constricted. Other GI issues like diarrhea, constipation, slow motility, and there's even more than that. Now remember, there's all these different autonomic nervous system disorders under the dysautonomia umbrella. That means there's so much overlap in symptoms and in how they're treated. The suggested treatments for POTS and OH are, for the most part, the same. But of course, there's going to be some differences, especially if your doctor is giving you individualized care, which they should be. So right now, we're just going to go over the very basic first-line treatment that most POTS and OH patients are told as soon as they are diagnosed. Wear compression garments, increase fluids, and increase sodium and electrolyte intake. And most people with OH are told the same exact thing. Pause and notice that we're reaching the 5-minute mark on your timer, so prepare to take your heart rate and blood pressure again. Continue standing. Make sure that you are checking in with yourself. You are not swaying. You are not shifting your weight back and forth. You're halfway there. Also, as another reminder, please don't faint. Okay, please don't make yourself sick. If you need to sit down or lie down, please do it. So, very common first-line treatment for POTS and OH, these lifestyle changes. First, let's talk about compression garments. People with POTS and OH often experience blood pooling. When we stand, our blood begins to pool in the lower half of our body. That happens because of the lack of efficient blood vessel constriction. As a result, the longer they stand, the more blood is pooling, the less blood is returning to their heart. That, of course, leads to symptoms of orthostatic intolerance like lightheadedness, dizziness, and fainting. And this is where POTS and OH are different. When someone with POTS is standing and they're experiencing blood pooling in the lower half of their body, their heart rate is going to increase significantly to try to compensate for the lack of efficient blood vessel constriction. It's trying to maintain adequate blood flow to the heart and brain. Obviously, it doesn't work out so well, which is what causes symptoms. With orthostatic hypotension, remember we're talking about neurogenic OH, the type of dysautonomia, that significant increase in heart rate, that is the heart overcompensating, doesn't happen. There's a severe lack of efficient blood vessel constriction, which causes the blood pressure to drop, and there's little or no heart rate increase. So low blood pressure, not enough blood returning to the heart and brain, symptoms. So the whole point of this blood pooling thing is that compression garments aid in that lack of efficient blood vessel constriction. They compress, they squeeze, they help lessen blood pooling and aid in getting the blood back up to the heart and brain, which should, hypothetically, improve symptoms of orthostatic intolerance, like that lightheadedness, dizziness, and other symptoms patients get when they are upright. Now, the other lifestyle adjustment that POTS and OH patients are encouraged to make is, like I said, increasing fluid, sodium, and electrolytes. But why? Increasing fluids and sodium help in both conditions because they increase blood volume, which means they give the body more circulating blood to work with. So more blood volume means there's more pressure in the system, and that helps reduce the amount of pooling, of course, which improves blood return to the heart and brain, and that helps stabilize blood pressure despite the lack of efficient blood vessel constriction. POTS is often associated with low blood volume. It's called hypovolemia. That's one subtype of POTS. That's another story, the subtypes of POTS. Of course, OH is defined as a significant drop in blood pressure. So both POTS and OH benefit from extra fluids and sodium because they support circulation even though the blood vessel response isn't strong enough. So here we are, we're nearing our last 2 minutes of our active stand test. Whether you are still standing or whether you had to sit or lay down, I'm very proud of you. Obviously, no one is having a good time. We've got about 2 minutes left. Let's talk about what you should do if you're concerned about the results of your active stand test. With the disclaimer again that this video isn't meant to be used as a diagnostic tool and you should always speak to your provider about any concerns. You probably saw this coming, but of course the first thing I'm going to suggest is taking the results of your test to your provider. Now, I want to pause there and recognize I know there are so many barriers that keep so many patients from accessing the care that they need and deserve. But if you have access to and you have the means to, please continue this conversation with your doctor. Now, I know how nerve-wracking it can be to go into an appointment with something like this to try to advocate for further testing, especially if you have a history of being met with medical gaslighting. I can only tell you how I would personally handle it and what I would say. So if I was not yet diagnosed with POTS and I had done an active stand test and found the results concerning, if my symptoms seemed to line up, I would make an appointment with my doctor. I would bring the results of my active stand test along with a list of my symptoms, how long I'd been experiencing experiencing those symptoms, as well as a list of things that make my symptoms worse or even that cause my symptoms. I'd sit down with my doctor and all of this information, and I would say, for the last couple of months, I've been experiencing X, Y, and Z symptoms. I realize that my symptoms are happening and worsen when I go from lying or sitting down to standing up. I've been really careful about changing positions very slowly. It doesn't matter if I sit in between. It doesn't matter how slowly I get up. I still, once I am on my feet, or if I've been on my feet for a little while, I start to feel really sick, lightheadedness, dizziness. I feel like my heart is beating out of my chest. So I decided to take orthostatic vitals to see what my blood pressure and my heart rate were doing when I'm lying down versus when I'm standing up. And I found the results kind of concerning. So I wanted to bring the results to you along with a list of my symptoms and my symptom triggers, and see if you think it'd be worthwhile to further investigate POTS and maybe pursue more formal testing. Now, once you've shared your story, shared your concerns, hopefully they will be validating, hopefully they'll hear you out. And if the results of your active stand test do look concerning, hopefully they'll take next steps, whether that is pursuing formal testing, if they know what they're doing, or perhaps referring you out to a neurologist, an electrophysiologist, or a cardiologist. Now, you might be thinking, if dysautonomia, if POTS, OH are not heart conditions, why would I be sent to a cardiologist? Remember the last piece of the POTS diagnostic criteria. There must be an absence of other conditions explaining the tachycardia. Think about how many conditions cause POTS-like symptoms: tachycardia, lightheadedness, dizziness, heart palpitations, sometimes chest pain, and shortness of breath. Even just think about the overlap between POTS and OH and the other types of dysautonomia. Oh, let's pause and look at that timer. You made it to 10 minutes. Take your heart rate and blood pressure one more time. And quickly going back to there being so many different conditions that can cause the same or similar symptoms as these types of dysautonomia. That's why in an ideal world, every patient would be able to get a thorough workup from several different specialists to make sure that those differential diagnoses have in fact been ruled out, and that yes, this really is POTS, OH, or another type of dysautonomia. Thankfully, we're all done. I hope you are going to go take a well-deserved nap. Don't forget to hydrate, and if you're someone that needs extra sodium and electrolytes, make sure you get those in too.